Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about septoplasty incisions. Now this is a topic that I had a lot of confusion when I was in my postgraduate, and I'm sure a lot of other postgraduates as well have this confusion over here. Which one is which incision? Where do we put it? What is the location for it? And which one do we prefer when? So these are all questions that I'll answer in today's class. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So we have three incisions in septoplasty that we need to know about. The first one is Killian's incision. So if you look at this blue incision that you have seen over here, this is what is known as the Killian's incision. Now this is more commonly used in case of SMR. So Killian's incision is an incision that we place about 1 centimeter behind the caudal border of the septal cartilage. So this is the caudal border of the septal cartilage. You put it about 1 centimeter behind. Now this number you'll actually see in different textbooks giving you different numbers. So there's a range over here about 5 to 10 millimeter, but I would actually prefer to go with 1 centimeter over here, and this is in reference from the book Scott Brown as well as VP Sood. So 1 centimeter is the number that I would like to remember over here. So Killian's incision is an incision which is placed 1 centimeter behind the caudal border of the septal cartilage. So that is what our first incision is over here. Now usually we make this incision on the concave side of the deviated nasal septum. Now this incision we only give through the mucoperichondrium only. We do not go through the full thickness. So after we give the incision towards to the mucoperichondrium, up to the mucoperichondrium layer, then we raise the flap. So that is what Killian's incision is. And this Killian's incision is the typical incision that we use in SMR, which is submucous resection of the septum. Now, Killian's incision would be preferred in case the deviation is a bit posterior and when you do not have any plan for performing rhinoplasty, because Killian's incision cannot be combined with a case of rhinoplasty. In a case where you need to perform rhinoplasty as well, Killian's incision will not be the preferred incision. In that case, you will perform other incisions. So, the reason why Killian's incision is preferred to be done in the concave side of the septum. You can even perform it on the convex side. It depends on your preference. But usually it is done on the concave side of the deviation because number one, it gives you better visualization during the time that you're elevating the flap. Second, it also is easier to enter the subperichondrial plane on the concave side rather than the convex side. So that is also a point. And thirdly, there is less scarring that occurs if you do it on the concave side. So these are the three reasons why we will prefer to do it on the concave side of the deviated septum rather than the convex side. And we will use this incision classically in submucous resection, and we'll prefer to do this if the deviation is very posterior and we do not have any plans for rhinoplasty. The advantage for doing a Killian's incision is that it preserves the caudal septum and the L strut, which is the caudal and the dorsal strut, which forms the L strut. So Killian's incision helps us in preserving the caudal septum because the incision is placed about 1 centimeter caudal or behind the caudal border of the septum. The disadvantage of Killian's incision is that if you have any caudal septal deviation, you cannot access it with the help of this Killian's incision. And also you cannot combine it with rhinoplasty as well. So that's about Killian's incision. So this is an incision that we place 1 centimeter. Remember this number. In a lot of books, you'll see even 5 millimeter also written. That's a range that is given in different books. But according to Scott Brown as well as VP Sood, the number 1 centimeter is given. So let's remember that. So it is an incision that we give on the concave side of the deviation, primarily because of three reasons. First of all, there is better visualization during the time of flap elevation. Second, it is easier to enter the subperichondrial plane on the concave side. And thirdly, there is also less scarring when you go from the concave side. And this is the classical incision that we use in case of SMR, and we cannot combine it with rhinoplasty. So that's our first incision. Now let's move on to our second one, which is the Freer's incision or the Hemitransfixion incision. So these two incisions, they are just the same with two different names. You can either call it a Freer's incision or you can call it the Hemitransfixion incision. If we look at the image over here on the right side, the one which is marked with red, this is where the Freer's incision is given. This is an incision which is made at the caudal border of the septal cartilage. And this incision is only made on one side only. That is why it is also known as hemitransfixion incision, meaning hemi means half. So it is only made on one side. That's why this is known as hemitransfixion incision. Now, the advantage of this is that it will give you access to the entire septum, right? You're able to see the entire septum, including the caudal part of the septum, which you were not able to get when you put a Killian's incision. And Freer's incision is the most commonly used incision in septoplasty in today's times. So now this Freer's incision or the hemitransfixion incision, it can be of different types. The length of it can vary depending on the amount of access that you require in your particular surgery. So if you look at this image over here, this is what a partial hemitransfixion incision looks like. It extends from here to here, meaning this is a partial hemitransfixion is a limited hemitransfixion incision, and this is used when access to the posterior septum is not required. So you only give an incision for this much area, and this is done when you do not need to access the posterior septum. Then we have the second type, which is the full hemitransfixion incision, which is extending from here to here. So you extend the incision further over here along the entire caudal margin of the septal cartilage, and this full hemitransfixion incision is required to allow complete access to the L strut, including the caudal septum. And the third type that we have over here is the extended hemitransfixion incision, where you further extend the incision towards the nasal floor, and this is done when access to the floor of the nasal cavity is required. So you can see how hemitransfixion incision can be extended and can be of different length depending upon the access that you require. We give a partial one when we do not require any access to posterior septum. We do a full hemitransfixion when we want to allow complete access to the L strut as well as the caudal septum. And we do an extended hemitransfixion when we require access to the floor of the nasal cavity as well. So this is how you can have the three different types of hemitransfixion or the Freer's incision. Now let's talk about what are the advantages of Freer's incision. Now this is a very, very important Viva question that you will be asked from time to time. So Bernstein had given us all these advantages. Why Freer's incision has these advantages. Number one is the incision is placed in a relatively avascular site. So during the time of surgery, when you're putting at the an incision at the caudal border of the septal cartilage, this is actually a very avascular site, and there's very less chance of bleeding and very clear operative field when you're performing the surgery. Second is the mucosal edges over here are very thick and tough. Thus, it reduces the risk of any tear happening to the flap, the mucoperichondrial flap. And even if a mucoperichondrial flap tear happens, you can easily perform a good repair of the flap. So the mucosal edges are very thick and tough in this particular region. Third advantage of the Freer's incision is it provides easy access to the whole of the septum, including the caudal septal border and the anterior nasal spine. So if you have any caudal septal deviation, Freer's incision is the incision that you will be picking, not the Killian's incision. Because in Killian's incision, you cannot access the caudal septal border. Next, the fourth advantage is it provides an easy approach to the anterior septal dislocation, which I just mentioned. And fifth one is it can be easily converted to a complete transfixion incision when you want to perform a rhinoplasty. So these are the 5 different advantages according to Bernstein of the Freer's incision, and this you should remember by heart because this is a very common question asked in your Viva questions. Now, there are also certain disadvantages to Freer's incision as well. Here, there is a slightly higher risk to L strut if you're not careful. So, L strut is the caudal and the dorsal strut that we maintain in when we are performing any septal surgery, so that there is no external nasal deformity that can happen as a complication of the surgery. So here, because you're accessing at the caudal border of the septal cartilage, there is a higher risk that you may not end up preserving this L strut at the caudal as well as the dorsal strut while performing the surgery. So you have to be extra careful over here. And second is there is a risk of columellar retraction if the closure is not done meticulously. So that's also something that you should be careful about. So that's about the Freer's incision. I hope I have cleared any confusion regarding what is the difference between the Freer's incision and the Killian's incision. What are the advantages of each? Where do you use it? And also the different types of Freer's incision. Lastly, we have a third type which is known as a transfixion incision. Now, this is an incision the same as hemitransfixion incision, but this is an incision which is made on both sides of the caudal septum and thus separating it from the columella. Now, this incision goes through and through towards the opposite side from the one mucocutaneous junction to the other around the caudal border of the septum. And this is an incision that we perform when we are going to do a rhinoplasty combined with septoplasty. So the advantage of doing the transfixion incision is that it gives you maximum exposure. Entire septum will be accessible from front to back on both the sides because of this incision. Second is it gives you direct access to the caudal septum, columella as well as medial crura. And third is it is essential when you are combining rhinoplasty along with the septoplasty. So these are the advantages of transfixion incision. Next, the disadvantages of this transfixion incision is that it cuts through the septocolumella ligament. Now, what is the septocolumella ligament? This is a fibrous attachment which is there between the caudal septum and the medial crura. So, because it cuts through this ligament, it can have a higher risk of loss of tip support. So, you can end up with some kind of a tip deformity, a tip depression. And the second is a transfixion incision also has way more tissue disruption than the other ones. Therefore, they have a higher chance of post-operative scarring. So that is why transfixion incision is not the commonly used one. If you are thinking of performing a rhinoplasty along with the septoplasty, in that case, this incision becomes the incision of choice over here. But otherwise, Freer's incision is the most common septoplasty incision used in today's time. So that's all for today. If you have any doubt regarding the septoplasty incisions, you can note them down in the comment section and I'll get back to you. Thank you.